All right. Good morning, everybody. Welcome to the February 24th meeting of the North Dakota State Health Council. We have an agenda in front of us. First, let's do a roll call so we can identify that we have a quorum or not. So, Miranda, would you like to do a roll call?
Sorry, I had to unmute.
Okay.
Birch.
Here.
Brusso.
Here.
Dienstmann.
Here.
Fedorchak. Fedorchak. Lenoy.
He doesn't plan on participating, so.
Okay. And I know Tyler
Yep.
will not be here today. Poole.
Here.
Roars.
Here.
Saylor. Saylor. And Wolf. Five present, 4 absent.
Okay. I believe that's sufficient for a quorum, right, Dirk?
Yes.
Okay. All right. Then you have an agenda in front of you. Are there any additions or deletions to the agenda?
Dwayne, do we need to add the December minutes onto that agenda?
I think the revised agenda had as item number 1, November minutes and December 16th minutes.
Okay, thank you.
I think
Jim, would you like to add?
Jim, yeah, I was going to say that Bridget Widener said she was going to be present on the committee or on the meeting, and she would give a report on the nursing home issue that we took up last time.
Okay.
So we could maybe add that under other business.
All right. We'll add it under item number 8 then.
Yeah.
Hearing no other additions or deletions. Do I need a vote to move that forward or just as it is?
I think you can just do a voice vote.
All right. Voice vote. Those in favor of the agenda as amended?
Aye.
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 The agenda is amended. First, the November 18th minutes. Are there any additions, deletions, edits, issues with the meeting minutes as presented?
This is Jim. I'll move to approve the minutes as presented.
We have a motion to approve. Do we have a second?
I'll second. This is Jenny.
We have a second. Any further discussion? Hearing none. May we have a roll call? Miranda.
Birch.
Yes.
Brusso.
Yes.
Dienstmann.
Yes.
Poole.
Yes.
Roars.
Yes.
Moving on to the December 16th special meeting. Are there any comments, additions, deletions to those meeting minutes?
This is Daryl. I would move to approve.
We have a motion to approve. Is there a second?
Second.
Motion to approve in a second as presented. Any further discussion? Hearing none. Miranda, may we have a roll call again?
Birch.
Yes.
Brusso.
Yes.
Dienstmann.
Yes.
Poole.
Yes.
Roars.
Yes.
All right. Next, we have Dr. Masson with an update from the state laboratory. You are on mute.
No, we can't hear you, Christy.
Christy, the buttons are at the very bottom. Oh, okay.
Yeah, I'm unmuted. Can you hear me now?
We can hear you now.
Okay. perfect. It just must not have liked the microphone that was selected. Sorry about that, guys. Good morning, everyone. Here at the lab, we continue to stay fairly busy. We are seeing a reduction in the number of samples that are being submitted to us through PCR, which is kind of what we expected. So we have adjusted some operations here at the lab to kind of meet that need. So we have reduced our hours. We are operating long days, Monday through Friday. So we operate from 7 to 11:30 p.m. Monday through Friday. And then we're just operating one shift on the weekend when the volume is incredibly low. There's not a lot of testing events that are coming to us. So we just operate from 7 to 3:30 now on the weekends. And we've been able to still meet our turnaround times given those reduced hours. We have reduced our temporary staff. Not all of them. At one point we had 180 employees. We are down to between 80 and 90. I don't know what my current count is as of today, but between 80 and 90 temporary employees assisting us with the response. But during the week, when we have the extended days, we anticipate that we can perform still up to about 6,000 tests per day, given surge capacity. So if we would get another wave, or we would, see an increase in demand for PCR, we would still be able to accommodate that need. I did just want to touch back around on our Amplitude system because I know that got a lot of attention because that was a really big problem for us here in the lab. The Amplitude system comes from Thermo Fisher, and it is an automated system, a fully automated robotic system for the Thermo Fisher platform that we were running before we got the automated system. And if you guys recall, we came across an issue with samples that needed to be inconclusive back in November and December. And then we actually, or December and then January, but we went all the way back to November, and we actually looked at the entire time that we used the instrument because we were concerned that there was problems from the beginning, from day one. And that was true. We did find a significant number of issues with samples. We ended up having to change 641 results after digging through, thousands and thousands of results. We changed 641 to inconclusive, which was really unfortunate. And I know it's caused a lot of problems. But I just wanted you guys to be aware that that's because we wanted to make sure that we have the most accurate data. We're giving the best numbers that we possibly can, so that there's no false negative, false positive results out there that we potentially knew about that we never fixed. So this is us just really working hard to make sure that our quality of results that go out is as high as we possibly can make it. So there was a couple of issues associated with that. One of them was a dirty block, which might not mean much, but we got that cleaned, and that did clean up some of the issues. However, there still appears to be a software issue that we are not entirely comfortable with. And we are still working with Thermo Fisher to get them to understand what it is that we are not liking about the software. They did roll out, I think it was about 2 weeks ago, a software upgrade. We brought that software upgrade in, we implemented it, we revalidated the system, which was great. However, we still don't totally trust the system, and so all of those results are still reviewed manually. So we are still double checking everything. We probably will until we're comfortable with it, and until Thermo Fisher comes out with a statement that says exactly what the issue that we're seeing is and how they'll fix it or address it, etc. So there shouldn't be any issues with results going forward, just because we have people that are watching it really closely, which is unfortunate because the whole purpose of that system and that interpretive software is to not have to do that. But when you don't trust the software, your only option is to review it. So we continue to review it because we definitely don't want bad results going out there. We always want to have the best result possible. And that system is what is allowing us to maintain our capacity with less staff. So it's definitely an important system to our process and our operations. And then on top of all of that, because right in the middle of a pandemic is the best time to upgrade your LIMS system, but we had started an upgrade before the pandemic started, and now we're up against the deadline to finish that. And so we are going to be switching over to a new system. There's a great team that's working really hard on that. We are trying to move to a paperless system starting March 15th, and then hopefully being able to go live April 1st. These dates, of course, are tentative and subject to change because we know how these things go and nothing goes according to plan. But we will have to have this system upgraded by mid-June for sure. So sometime between April 1st and mid-June at the worst case scenario, we will have a new system in place. And then I think my last update for you guys, unless you have questions for me, is to talk a little bit about whole genome sequencing. So as PCR demand diminished, we were able to allocate more resources to doing whole genome sequencing, which of course is really great. It gives us way more information about the virus and what virus is actually circulating in our state at the time. So we get to map out more of the genetic sequence and see potential variants. So, for example, one of the things that we're doing is looking at the 3 CT values for the PCR positive samples because we have 3 targets that we're looking for. It's the N, the ORF, and the S gene. And that S gene will have this what we call drop-off. And so we'll see a significant increase in the CT value, or the CT value will become negative. And the sample will only be positive for 2 of the 3 targets. So the sample is still positive for coronavirus, but it's an indicator that there's a potential variant, specifically like the UK variant or the one that we're seeing like in the Connecticut area, things like that. So we then take those samples and we move them onto whole genome sequencing. But because we don't have a way to screen PCR for the other variants, like the South African and the Brazilian variant, we still are taking a random sampling of our positives and pushing those through to whole genome sequencing. So we're monitoring for all of the variants as best we can. In addition to that, we supplement what we're able to do by sending 17 samples every 2 weeks to the CDC for them to also do whole genome sequencing on. We do report all of our information to the national database. And then we also are encouraging labs out there that are running PCR to submit their positive samples to us so that we can add them to our random sampling of whole genome sequencing so that the ones that are being done outside of our laboratory don't get missed as well. And I think that's the update from the lab, unless you have questions for me.
Jim here, I've got a question for you.
Yes, go ahead.
Okay, is this? I'm getting some feedback here from my phone. Anyway, my question is, are you seeing a change in the positivity rate in your screening studies? Has the positivity rate dropped down or stayed the same? Or?
So, I mean, our positivity rate, it seems to match what we're seeing get reported from the entire state. We're not seeing like a drastic difference between what we see on a daily basis versus what we're reporting as a state. Is that your question?
Yeah, I was just wondering if we're having more positives or more negatives. If you've got fewer tests being run, are there hotspots in the state, or is there some kind of a regional difference that you can report on, or is that kind of outside your area?
You know, that might be a little bit outside my area. Kirby Kruger would be able to answer that question for you, though, I bet. Kirby?
I would add on to that, Jim, and I think this is where you're getting is there a difference in the population that's being sampled now compared to several months ago?
Yeah, that's part of my question. And then I was also wondering, with the reduced number of tests being done, if we're seeing a difference in the positivity rate. I can wait and ask Kirby that when he comes on board. That's fine.
Or I can address it right now.
Oh, Kirby's there. Okay.
Yeah, I am here. Yeah.
Hi. Good. Okay.
I don't know. Do I got my camera on? I should look. Yes. Okay. Thank you. Yeah. And So Christy has access to the data that her lab produces, but on a daily basis, I get a chance to take a look at all the lab reports that come into our surveillance system, the MAVEN system in North Dakota. And just to give you an example of testing, you know, back in July, we were averaging about 4,245 test reports a day, our lab results a day coming into MAVEN. We peaked in November at 9,202 test results per day. That's an increase of about 117%. And that's an average per day. Since then, we've dropped about 52% down. We're down in February, we're averaging about 4,931 tests per day. There was a transition in some of the testing that started to occur as the antigen tests became more available in October. And what we're seeing now is that almost 39% of our test results coming into MAVEN are now antigen test results and not PCR. So close to 40%. And there are some days where antigen testing does exceed PCR. It's not very many, but there are some days where the antigen testing actually does exceed the PCR testing in the state. We are seeing some differences in testing. And I think one of the things that I look at every morning when I wake up is I get a list of the different test results reported out of by county of residence. And so what I see is, especially in the more rural areas, what looks to be diagnostic testing occurring. Small numbers of tests, higher positivity rates, to me suggests symptomatic individuals coming in and being tested. And when I look at the data from the larger counties, when they do their larger events, positivity runs between that 1% to 3% depending on the day. But when I look at the smaller counties, I'm seeing small numbers of tests with higher positivities running, you know, anywhere from 10 to 50% depending on how many tests are being run. Okay. So I think there's been a definite shift to symptomatic testing, and there's been a shift away from these larger community type events where asymptomatics show up. And Christy can attest that testing is down, and even positivity at our lab is down. When I look at the positivity over time, you know, especially going back to November where we peaked, it's down. This morning, positivity at the public health lab was 1.2%. So,
did that address your question, Jim? And then I believe Dirk has his hand up.
Yeah, that answers my question, and very, very interesting. I've been following it from Grand Forks County, and it's really been quite dramatic how the number of cases have fallen off there, probably elsewhere in the state too. I was also wondering if there was still a regional difference in, say, hotspots for the virus, or if there's anything to report along those lines.
You know, transmission is still occurring. And what I'm noticing more is that those rural areas that are doing testing more consistently, even if it's just symptomatic testing, they're continuing to see cases. These rural counties, you know, they'll test 4 or 5 a day, but they get 1 or 2 positives out of that, you know, and so, yeah.
Dirk?
Yeah, and Dwayne, my comment is just tacking on to what Kirby is saying is our profile has changed a bit. At the peak of our testing, 60% of that testing came from long-term care facilities who had to test, you know, multiple times a week, just based on CMS guidelines. And because our positivity rate is so low now, that number is dramatically different. They may have to test once a week or once every other week, and it may just be staff. So it's a different testing environment for those where a bulk of those numbers came from. So that would be the other change, that just for people's awareness.
So Dwayne, I have a question for Christy, if I might.
Harold?
Christy, when you talk about your inconclusive testing that's taken place, you know, obviously there was concerns with those folks who were tested that period of time. Have you done any reporting back to the CDC or Health and Human Services on some of the potential impact that it might have had on long-term care facilities and some of their quality payments?
Yes. So Nicole Burnell and Bridget Widener have helped us try to communicate back what's the best way to let those folks know for those that are impacted, because there was a handful of long-term care facilities that were impacted. And then we are working to see if there's anything that we can do to notify the FDA as well. But we're working with lawyers and things on that.
So are you aware of any outcomes from those discussions yet?
No. Bridget may have an update, but I hate to put her on the spot. Bridget, do you have anything to add?
I'd be happy to add, Daryl, we don't really have an answer yet back from our federal partners. We did submit the question to CMS. CMS directed us to HRSA and CDC directly. CDC because of the NHSN as part of the CDC. HRSA did respond that we need to be working with CDC through the NHSN, and they have not responded, unfortunately. So we do not have clarification as to how it will be handled. There's been multiple emails that have gone to CDC looking for a response, but at this point, we have not gotten anything back.
Thank you, Brett.
I think this isn't really a question, but maybe a comment. One of the other things is not just the quality outcomes and how that could affect, reimbursement and that kind of stuff, but the impact to the residents and their families because of the way that the CMS rules are right now that lock them out of visitation for 2 weeks. And so just awareness of the kind of social impacts as well.
Thank you. Are there any more questions for Dr. Masson? Thank you, Christy. And I'm glad you guys are finally getting a little bit of a normal life again. It's not exactly normal yet, but it's getting closer.
No, but we're able to catch our breath, which we all appreciate. So thank you.
All right. Is Dr. Carlson on the line? All right, we'll skip over Dr. Carlson for now. Is Bobby on the line? Bobby, I see you on there somewhere.
I wasn't unmuting. Sorry.
Bobby, do you want to do the veterinary loan repayment program as well, or just the SLRP and Fed?
Just the SLRP and the federal.
Okay.
Or I'm sorry, the state and the SLRP, which is the federal.
All right. We'll move to item number 4 on the agenda until Dr. Carlson comes on.
Okay. I'd like you to refer to the loan repayment default summary that was sent to you. And we're going to need to vote on 4 out of the 5 of these defaults. And I'm assuming, obviously, we're going to have to vote one by one. So if we want to take a look at Jenna Johnson, if I would take any questions, if you have any before, or if you have any discussion on her letter.
Since several people are on the phone, do you want to just provide just a really quick brief on each one of them, and then we'll discuss them? So
she was at the North Dakota Youth Corrections Center and did take a move to a private practice. And she was previously in Bismarck and is now still in Bismarck. Her caseload, if you looked at the letter, does not meet 100% Medicaid patients. She does do 25% of Medicaid at her private practice. And then she's in school-based programs for 12%, and then works with youth for 10%. So she is still hitting the population at her private practice, but she is asking if she can continue in the program.
Bobby, is there a percentage of Medicaid that the facility that they were working at was supposed to service, or is it just that they accept Medicaid?
Correct, just that they accept Medicaid.
So by the standards that we would have for anybody starting new, this would still be considered a qualifying role
Yes, it would.
in a service area that would meet the standards?
Yes.
Other questions for Bobby with regard to this particular default?
Bobby, one question I did have in regards to that. So 25% is Medicaid, 12.5 was for Legacy High School, and then 10% was for telehealth. So do we know what the other, is she working part-time, or was she just specifically just sharing what was part of the program? I guess I wasn't sure on that. I'm assuming it's full-time she does, but it only comes up to 47.5% of an FTE for her client or case base.
Yeah, very good question. She is working full-time. I do verify that everybody does comply. Otherwise, I would just put it as a default. It would be private pay, the rest of her population. She wanted to make sure that you saw what she did with the underserved populations that we focus on.
And just to reiterate, the percentages that she is showing here does meet the qualifications for the program.
Yes, Century Code only states that they accept Medicaid. We don't have a percentage in there.
So one other question, was there a employer match on the other side of this one as well?
Yes, and I do make sure that there is a match again before I move them forward, because if there isn't, they would be in default.
Okay. Sorry, I'm dotting I's and crossing T's.
Mm-hmm.
And you're already doing that for us, so I should trust you more. Any other questions for Bobby?
Trust but verify, Dwayne.
Yeah.
Hearing none, is there a motion on the Jenna Johnson deferral? Or sorry, default.
So the options are to accept the change or move to default. I just want to make sure I know what the motion options are.
Yeah, the motion options would be to continue her in the program with her change or to put her in default. Is that correct, Bobby?
Yes, it is. And the only thing that I would also say that we can't consider right now is when they apply, we get to look at all the other applicants. So we can look at those that are serving in more of an underserved population. With her 4 years into the program, we're not able to say that she's serving a higher unmet need population because she's not sitting here, against other applicants. So that's where it is a little hard. I can't say to you that she's serving a more underserved population than the other candidates at that point in time. So, but yes.
So do I have a motion?
I move to continue her program.
We have a motion to continue. Is there a second?
I would second that.
Seconded by Daryl. Any further discussion? One of the points that I would want to make is that she's in her final 6 months of her program as well, and is still continuing to serve at least a reasonable proportion of Medicaid patients. So I think the risk is relatively low in that context, but I want to make sure that we have a consistent standard that we apply to everybody. So hearing no other comments, I'll call for the roll.
Birch,
Yes.
Russo,
Yes.
Dienstman,
Yes.
Poole,
Yes.
Roars.
Yes.
And Jenna Johnson is approved for continuation. As a momentary side note, are there any other council members who have joined the call at this point? Okay, let's move on to the next one, Bobby.
Okay, Carissa Kutzman. This one is actually a different one. I have not experienced this in the 4 years, and I don't know if any of you on the Health Council that were here prior to that have. Century Code does say works full-time. It doesn't say paid full-time. So she is continuing to work full-time at her facility, still seeing her patients, but because she's continuing her education, she actually cannot be paid for part of her hours now because that's part of her internship. So we're bringing this before you. She was wondering because she is not being paid full-time. She is working full-time. Can she still be in the program?
This is Jim. So as a student, she's being supervised in everything she does as a student, and somebody else is actually taking the responsibility for her work as a student. Is that correct?
You know, I did not ask her that question. I would assume, but I don't want to make that assumption.
No. Well, it kind of sounds that way to me. It'd be like approving a loan to a medical student who's still in his internship or something like that, because they're really not serving independently. There really is somebody else who's responsible for their work. So to me, that is a different situation. I don't know if anybody else has any concerns about that, but I don't know if we can, to me, it sounds different.
I agree, Jim. I was sort of thinking some of the same things in that, what did it mean from a policy perspective? Are we turning this into a internship fellowship program, or is it a recruitment upon a completed skill set program? Any other questions?
Bobby, how many years has she been in the program again? What is it, in 19? Is that correct?
So, yes. So only a year and a half.
Could we, this is a question, since she was approved, could we postpone it for a year or delay it for a year's payment while she goes through her internship, and then she could instead of having to reapply? I don't know if she's still in the same place and she's still serving, meets all the minimum qualifications, but if this is just a short-term internship, is there a way we could put that on hold, maybe for a 6-month period or however long that is, and maybe prorate this year's payment? I'm not sure.
Answer that, yeah.
Hi, good morning.
Sorry, Bobby, I didn't hear your answer.
I just said I would love Brenda to answer that question.
If they can defer it or put it in advance. Yeah.
Yeah, good morning. The thing with deferring and putting in advance really complicates the appropriation process. So her payments were appropriated for 5 years. So by doing that, it takes up a slot payment. You might tie up another slot for us to stay within appropriation. It's hard for us to know if, we're allotted and appropriated a certain amount for loan repayment. So to make that happen, we would have to find funds from another area of the budget.
Jim here again. Maybe she could provide a better explanation to us for our next meeting, and rather than defer the payment, maybe she can explain exactly what she's doing right now.
I think one of the interesting things, go ahead.
Nope, I was just going to ask, outside of the supervision concern, is there anything else specific that you would like me to explore further with her?
I think when you're in an internship position or a training position, you're not making the final decision on anything. You're really doing some good work, I'm sure, but then you have to have approval from somebody else. So the buck stops with the next person above her, and that's where I'm a little concerned.
The place where it got a little muddy for me is that prior to going back to graduate school, she was a completely functioning individual in her profession. So then it became the question of, in that advancement to a higher level of education and qualification, is she still unsupervised, capable of providing the decision authority and the guidance that she's doing for her volunteer hours, or does it require the supervision for her to be able to do the work that she's doing now under the volunteer side?
Okay.
Does that make sense, Jim?
I was going to say, go ahead.
I was just going to say, if she could clarify this, and then we're satisfied that she's actually doing independent work, and we took it up again at our next meeting, maybe we could reconsider this situation then.
That's what I was just going to state too. If this is more of a reporting on what she's doing to receive the credit for the internship, but is still making the independent judgment, I think that's a whole different set of how we could look at this, rather than having to get her work approved by someone per se. If she's still able to make those decisions and just report in what she's done, it would be good to know that.
Okay, sounds great.
So this one is tabled.
Okay, next we have Corey Stocky. She did lose her position during the pandemic. Her facility closed, so she was asking if she can stay under the program in her new facility. And she is still serving the same client base.
And the facility would still be a qualifying facility?
Yes.
Willing to match?
Yes.
Any more questions for Bobby over Ms. Stocky?
Well, I sure think it's fortunate that she continues to serve that population in that area, because there's certainly need there, and it certainly isn't her fault that her employer was needing to discontinue their business, but she is, again, seeing clients in that area. I would move to approve this.
We have a motion. Do we have a second?
I'll second.
Seconded by Jenny. Any further discussion? Miranda, would you please take a roll call?
Birch,
Yes.
Brusso,
Yes.
Dietzman,
Yes.
Poole,
Yes.
Roars.
Yes.
Final vote is 5 ayes, 0 nays.
Motion's approved. Okay, Bobby?
Okay, we'll continue on with Nancy. She again moved facilities, but it was her personal choice to do so. But she is still serving, actually, she's probably serving a more underserved population now. This one has been quite delayed on her sharing the information. And again, that was because of the match. I do verifications every year from April and May because they're paid in June. And so she was still in her location in April. It did take us until last week to secure her match. So she would fit all of the qualifications now. But she has been in her new location almost a year.
And just want to verify, Bobby, I know she's working for social services, county social services office or regional social services. There's no issue with that, correct? That it's.
Any discussion or a motion?
I'll move to approve that she can continue in the program.
We have a motion from Jenny.
Jim Russo, I'll second.
We have a second. Any further discussion? Hearing none. Miranda, would you mind taking a roll?
Birch,
Yes.
Brusso,
Yes.
Dienstman,
Yes.
Poole,
Yes.
Roars.
Yes.
5 ayes, 0 nays.
Motion passed.
Dr. Uran, she just wanted you to have a letter. She is in default, so her contract will discontinue. She moved from large animal to small animal. She wanted to thank the Health Council and then share that she had left.
All right, so there's no action needed on this one?
No.
Information only? Okay.
Yeah.
All right. Brenda, thank you for bringing up the stranded assets issue, because I know that the legislature takes a really hard look at funds that are meant for one biennium or another that are stranded from use or for being applied during that biennium.
Absolutely.
Then the other document that I shared was just what I do share at each of our meetings, just for information on where we're at and who has received the federal state loan repayment program. And it is slower. Again, a lot of our rural facilities still haven't had much of a flow for extra income to do the match. And some of them still actually haven't even brought all of their staff back. So it'll be interesting to see at the end of the grant cycle where we're at with this program. For our second year in a row, it has been a challenge to fill all of those positions or to have all of our awards.
And are we going to remain on budget basically this year? And is that your expectation?
I do not expect all of this money to be used this year.
Okay. Was it included in carryover, Brenda? On the state side?
Oops. Hi, Dwayne and members. The money we allotted for the full grant award again for next biennium that we currently have now. So not knowing if we'd have carryover or not, the division did not bring forward a carryover request to include in the appropriation. Not sure if we're going to even be able to spend the full amount, so that might compensate if we're not able to spend the full amount, but also have carryover. So we have mechanisms in place to deal with additional federal authority should that become available to us during the biennium. We can go to the Emergency Commission, or if we have additional authority from other areas, it can be shifted.
Okay. Anything else from Bobby?
I would just like to share this will be my last meeting. I will be leaving the North Dakota Department of Health next Friday on March 5th. So they have some applicants and we'll be doing interviews for this position next week, or maybe even at the end of this week.
Well, Bobby, I would just like to say that from a personal perspective and from the perspective of those providers in rural North Dakota, thank you for all the work that you've done over the years. You've done a great job and you will be missed here, but I'm glad you'll still be helping and supporting the work of providers in service to patients. So thanks again for your work.
Yes, Daryl, thank you. And I would say that I've seen this program grow and mature an awful lot in how we look at things, the information available to us, the organization of the things that are available to us, the summaries that you provide every year have really moved what your position was, I think, forward. And I appreciate that.
Well, and it's always exciting with change and new people to see what the next person can bring to the position. So that'll be exciting for you guys as well. And I am going to the Community Healthcare Association of the Dakotas, so I will get to still work with our underserved facilities and patients and providers in the state. So I'm excited about that. I've accepted a policy and partnership position there.
Well, I'm not sure I speak for everybody, but I'm pretty sure I do. We wish you well in that. We hope to engage with you again.
And I'm not sure, I think I'll try to find out where Dr. Carlson is, because I don't see her name on here. So she will be, and I think you have other agenda items. So I thank you very much, everyone. I've enjoyed working with you.
Thank you, Bobby. So we'll move on to item number 5 on the agenda until Dr. Carlson shows up somewhere on the screen. That would be an update from Disease Control and Pathology Director, Mr. Kruger.
Hey, thank you, Chairman Poole and Health Council members. Thank you so much. I want to start out first just talking a little bit about the forensic pathology section, and really in the era of COVID here, they have been overlooked and not unrightfully so. They do an important public health service. Last July, we were able to bring on a forensic pathologist to join our team, Dr. Barry Miller. Dr. Miller, I asked to join so she could introduce herself today. This was after an extensive search. As you know, Dr. Mazzello resigned in July of 2019, so it took us a year to fill the position. We did eventually move to a physician recruiting agency to help us locate a physician, and it was helpful. And Dr. Miller joined us in July. She, during the period of COVID, she got her feet wet right away. She came in and she just had to do what she needed to do, and she's been working real hard. I'm very pleased that her background also includes a Master's of Public Health degree. So she has a very good background in public health, which is important. The forensic work that she does is really an important public health activity that needs to be done. Dr. Miller, if you're on, I'll just let you introduce yourself a little bit, okay?
Okay. Hi, can you hear me?
Yep.
Yeah.
We can hear you.
Got it. So I'm Dr. Barry Miller. I'll do a brief background. I went to the University of Minnesota Medical School and also got my MPH at the School of Public Health at the University of Minnesota. I did my residency at the Ohio State University in Columbus, Ohio. Came back to the University of Minnesota, did a cytopathology fellowship, and then went down to Fort Worth, Texas to do my forensic fellowship at the Tarrant County Medical Examiner's Office. And after I was done with my fellowship, I stayed on and worked as an assistant medical examiner until I came up here. So that's my background.
All right. Any questions for Dr. Miller at all?
I would just say welcome on board, and we're really glad to have you here.
Thank you.
We are extremely excited that she's with our team, and she's, I think, fitting in really well. She's been, I got to admit, she's been somewhat neglected during all of this COVID stuff, but she's really just dug right in and done a lot of good work already. Just a brief overview. In 2020, we did, in the Bismarck office, conduct 111 autopsies. There were 60 consults. That's down a little bit from previous years. And I think looking at UND's preliminary numbers, what they did, their numbers are also down a little bit. So I think autopsies in general were just down in North Dakota during COVID. Not unlike all of the other things that we saw decreases in there. We have less diagnosis and less reports from other reportable conditions. I think just less things happening in the medical field altogether outside of COVID. And so I guess I'm not totally surprised by that, but it'd be interesting to see how we progress now as cases in COVID drop down and people are trying to get back more to normal. So just a little bit in disease control. We have 27 FTE in disease control, and those positions have been really stable throughout the COVID crisis and the response, and I've been very happy for that. We've had a couple of individuals that left, but we've been able to get the positions filled, and it's worked very, very well. We filled the position over in Dickinson for one of our field epidemiologists, Nortriva Hill, and she started in late summer, but she's been doing a great job. Nortriva came in and we got her trained up to do a lot of work that our other field deputies were not able to get to all the time. So she really focused her efforts on the sexually transmitted infections, HIV, and some of the enteric follow-ups, as our other field deputies were focusing more on COVID. But we're happy to have her. And then we were able to move one of our full-time temporary positions into an FTE. Ben Schramm moved in to become our MAVEN coordinator. And so we were happy that we were able to get Ben into that position as well. So in that MAVEN coordinator position, that vacancy occurred very early in the pandemic response when Alicia left and went up to Human Services. And so we were happy to get that position filled. So we have 212 temporary employees that have been hired for the pandemic response, currently employed with us. Of that, 101 are investigators. Another 69 are on other teams. We have various teams that we've put together. We have teams that help with closing cases as investigations progress, making sure cases are properly closed. We have a team of individuals that look for interactions and clusters. That's their specific job. They've been assigned to regions, so they get to know their regions. And we have a team that addresses HAI infections and infection control situations. And so that team has been ongoing. We have a team that also responds to businesses. And then we have a team that over in Healthy and Safe Communities that works with the schools and doing the contact tracing for the schools. So we have various teams that have been put into place. All of them are put into place to help with contact tracing or to help identify clusters and investigate clusters. And as cases have decreased, our team has shown a lot of flexibility. We've been able to help out with hotline. We've been able to help out with connecting people to vaccine. Part of our team has been making phone calls to individuals who are 75 or older or 65 and older, trying to get them connected to vaccine so they can be vaccinated. Recently, Thrifty Drug asked for our assistance in helping to get people connected to their vaccines and helping people to get registered. So we stepped up to help with that as well. And so we are working, doing a lot of different things with our team. My goal is not to, we're getting some natural attrition. And as people resign, we're not replacing those individuals because we know we're going to have to downsize somewhere down the line. But my goal is to keep this team together as long as possible up until the new biennium. Before we start downsizing. The time it takes to get people trained, hired and trained is pretty lengthy. It takes up to 6 weeks to get a person fully trained to do case interviews and investigations. And so I'm not eager to let trained people go at this point in time when we don't know for sure where this pandemic is going to go yet. The numbers are encouraging, but really, if we can be flexible with this team and we can put them to work and they can help out with areas that include connecting to vaccine, assisting with hotline calls, and helping with data quality, I think that's great. And so far it's been working very, very well. And so we've just been very flexible with what we're doing with our team members. So, the other thing I just wanted to mention real quickly is, the grant funding that has been coming in. There's been 2 significant grants that we have staff working on. Molly in the immunization program has a grant for vaccines and immunizations specifically related to COVID vaccinations. That totals about $6.8 million. That money is good through 2024 or into 2024. That she's working on that grant and the specifics for that right now. That will need to be submitted shortly. And then Michelle Detloff is working on the ELC grant. That was a pretty good grant award, $43.8 million. That goes up into the end of July of 2023. Both of these grants have a heavy emphasis on health equity. So there will be investments in health equity with these grants. Both of these grants have an emphasis on improving data collection and applications for data. So we'll be looking at how we can improve our electronic disease surveillance system and improvements we can make to the North Dakota Immunization Registry in the Immunization Information System, NDIIS. There will also be grants to tribes, and there will be grants to local public health that come out of these, as well as, especially with Michelle's grant, sustaining a team of case investigators and contact tracers. So in terms of vaccination, I think Molly has just done an exceptional job of coordinating the COVID vaccine and the response to that in North Dakota. She's worked hard to coordinate with local public health and with the private health providers, including pharmacists. And, the percentage of doses we get into the state that are put into arms still remains very high. And I think that the ethics committee that provides guidance for North Dakota and makes the decisions on the priorities has done a very good job. And many places are moving through that priority list. There is quite a bit of difference in geography of how the vaccine is being accepted and vaccine uptake. The western part of the state it seems to be they're able to move some through those priority lists a little faster. The eastern part of the state are still higher up in those priority lists as they move through the priority list. We are making adjustments to vaccine allocation based on that so that we can get the highest risk individuals vaccinated as soon as possible. And so if there are areas of the state where vaccine isn't being used, those allocations are being adjusted. And so that more vaccine can be distributed to areas where that need is greater for those higher risk individuals.
So Kirby, this is Daryl. If I might ask a quick question. I think I read this morning that South Dakota's vaccine distribution was impacted with the weather down in Texas and the whole southern part of the country. Was North Dakota's allocation affected as well?
Yes, we did not receive any deliveries last week. That was due to the weather at the site where the vaccine is being held, the stockpile where it's being held nationally. So they weren't shipping from that site. They just weren't prepared for that kind of weather. And so it did impact. We are receiving all of those doses though this week, and we should be caught up with that as well. So this week.
Sorry.
Go ahead.
Sorry. If we're still on vaccinations, do you have projections on at this point, or have you looked at where the target is to the point at which we'll start to get to some level of herd effectiveness in the vaccine? And I guess I'd ask that question in the context of the supply chain, the operational ability to get it in arms, and then the demand side or participation rate, understanding kind of if we're not going to get there, what the limiting factors are.
Yeah, we remain optimistic. It is an ambitious goal, a 70% vaccination rate for those who are eligible to be vaccinated. We do expect that, I was just going to get to this, that we expect that the Johnson & Johnson vaccine will become available within the next couple of weeks, maybe as early as next week. We're not sure. And then we expect that Pfizer and Moderna will be increasing their allocations out to states, the amount of vaccine they have available, and that we expect to be mid-March or so. So we do expect more vaccine to start coming into the state. In terms of projections, I don't know if Molly may have something in mind, but I haven't really heard a hard number when we might get to that point, and I would hate to speculate. So. The other thing that I just want to mention, just in closing, is that we have an individual here at the Health and Disease Control that's been with us 25 years that will be retiring, Renee Lafferty. She's been our lead administrative assistant. As you know, administrative assistants are the unsung heroes in any office. And so she will be a difficult one to replace, but her plan is to retire. At first, she thought at the end of May. Yesterday, she came in and she thought maybe at the end of June. So I think she's still up in the air on that. But it will be a difficult position to replace, as she really does keep everything moving smoothly within the division. And I just wanted to let you know that's being planned, and we'll be working on getting that position filled. One of the qualifications, just so you know, one of the qualifications for this position is they have to be able to make scotcheroos as good as Renee's scotcheroos. Okay. So.
Jim here, just a comment. I noticed that North Dakota was doing better than any other state in the union in administering the vaccine that was made available to it. And Jim made me kind of proud to see that. But there still seems to be quite a bit of vaccine resistance in certain parts of the state. And I know I've talked to a lot of people who said they're still very suspicious of getting a vaccine. I don't know, you have any comment on that, Kirby?
There is. And you know, we've been trying to address vaccine safety. If you go to our website, our question and answer sheet has gotten so long that you have to have a search engine to get through it, you know. But we do try to address the different issues associated with the vaccine. And Molly's done news conferences and several news conferences with the governor to talk about different issues with the vaccine. So we are working hard. Dr. Carson at NDSU and his Center for Vaccine Research, he's done a lot of work to work with providers on how providers can communicate with their patients as well on this issue. And so there is work that's been done. We hear from people, well, I just want to see, I'll wait. I'll just want to see how this works and then I'll get my vaccination. But, you know, out of the millions and millions of doses that have been administered in the United States, we know that the vaccine has a high reactivity. You know, people react to the vaccine. They develop a fever or muscle aches or body aches and don't feel good for maybe a day or two. But generally speaking, severe reactions have been pretty rare. So.
And then there probably are many, many people who are asymptomatic when they're infected, so that the combination of vaccinations and these asymptomatic infections were probably a little closer to our herd immunity than we really know.
I suspect you may be right, Dr. Russo, on that. You know, within the next couple of weeks, we'll be coming up on 100,000 confirmed cases in North Dakota. And, you know, we're approaching that number now. And we know that's just what's reported to us, you know, and so we know that that's an underestimate of what's actually happened in North Dakota. Yeah.
And then I just had one last comment. I should have brought this up when our forensic doctor was on. I'm a little bit unclear on how autopsies and forensic investigations are done across the state. Are all of them reported to the state health department? Are all autopsies kind of reviewed by the state forensics officer, or do some not get reviewed?
So, Dr. Miller, I don't know if you want to take that or if you want me to take the lead and then you can just jump in. I don't know. She's still on. I see her name, but I don't know if she's.
Yeah, I'm trying to figure this out. Okay, yeah, you can go ahead and I'll jump in.
Okay, so in North Dakota, the system we have for forensics is that every county has a county coroner, and that's required by law. That county coroner is responsible for the investigation of deaths that may be due to unnatural causes, and really even may be involved in natural deaths where a natural death can't be ruled out completely, you know. So the coroners will make a decision on whether an autopsy, usually consulting with Dr. Miller or with Dr. Sens up at UND, whether an autopsy should be done or not, and then they'll make a decision. And if an autopsy is done, the autopsies are done usually at UND or NDSU, depending on the area of the state. We have a contract with UND with their Department of Pathology, the School of Medicine's Department of Pathology, because they have 3 forensic pathologists in that department, and so they've been contracted to help out with the workload that occurred in North Dakota, where it became overwhelming just for a single pathologist in Bismarck to do all the autopsies. And so that there's generally a decision that's made to bring the bodies in, and all the forensic autopsies are either done in Bismarck by our forensic pathologist, the state forensic pathologist, or by UND through that contract. So.
It used to be that autopsies were done to try to determine what the deceased actually died from. But now with all of our scans and everything, we hardly ever do autopsies for that reason anymore. So I'm just wondering, if autopsies are performed, do they all just kind of automatically become a forensic case then?
So the short answer, and I'll let Dr. Miller answer this, the short answer is that our office only does those autopsies where there may be a medical legal situation involved. It's really, we don't do any medical autopsies at all in our office. If there's a medical autopsy that a family would want, they would have to contract for that on their own. So.
Yes, that's correct.
Thank you.
So Kirby, I have a question for you. So we've been implementing the vaccination program since December, is it? I think.
That's about right, yes.
Are we starting to get any indication in terms of the length of time for efficacy for it? Are we feeling fairly comfortable that those that were early on are in relatively good position to help fight this disease?
Yeah, I think the overall message that we're getting from the people who know best is that, yeah, likely there's long-term immunity from these vaccines, but that hard data just isn't there yet because, the data that we have is been from the vaccine trials and now the limited amount of time that we've been able to vaccinate the general population. So I think that data, the hard data just isn't there yet, but I think there's a lot of optimism that these vaccines are very good and they're going to likely induce immunity even longer than what natural disease would induce. Currently, we're using the same 90-day window for vaccine as we are for natural disease in terms of immunity. And there's, So when an individual who has been vaccinated and they exceed that 90 days since their last vaccination in that series, technically they become eligible to be a possible reinfection if they develop symptoms and test positive again. So, and that's just sort of a surveillance definition that we've been using. So.
But the practical message is that it seems to be relatively effective and have some longer term benefit.
Oh, yes, absolutely. I think so.
Any more updates from Kirby? Any questions for Kirby? Any more questions for Barry? Dr. Miller? Thank you, Kirby. We appreciate it, and say thank you to your staff as well. We
All right.
appreciate everything they do.
We appreciate your support. Thank you.
All right. Let's see. Dr. Carlson, are you available?
Yes, I am so sorry. I have no good excuse other than my poor memory and a series of first world problems this morning. So I apologize for standing you up.
Well, that's all right. I think we have enough of an agenda that we were able to fill in until you're able to join us. We appreciate you making the time, though. We appreciate it. Would you like to go over the veterinary loan repayment program and the actions or decisions you need from us today?
Yeah, so I think that Miranda and Bobby had made sure that you guys had all the applications. And I think that you also have the final or the score summary of how they scored out. We only had 4 applications this year. They were all very good applications. They're all veterinarians that meet the, meet the criteria. 3 of them have been practicing for a few years. 2 of them had applied last year. The other, I don't think had applied before because she is currently practicing in a border state, but is relocating into North Dakota. So they were all very good. We all kind of had, there was a few placings that were a little different, but I think everyone that reviewed them was comfortable with how they came out. And so the top 3 were Dr. Mauk, Dr. Christ, and Dr. Dahl. And then Dr. Hansen, we really liked his application and would encourage him to apply again in the future. But he had only been in the position about 7 months or 7 or 8 months, I believe. So that was probably part of the reason. And then also his practice is located in Mandan, which one of the scoring criteria has to do with the size of the town they practice in. So even though he does cover a large rural area, which did give him additional points, he does practice based in Mandan. So that's kind of how they came out.
You have funding for 3 then, I take it?
Yes, I believe there's funding for 3. And I'm not sure, Brenda maybe knows the budget for the health department. One of the cuts originally presented was this program going forward. But as I understand it, that will likely be added back in, or has been thus far. I'm not exactly sure where that's at in the legislature.
Well, if Brenda's available or Dirk, we'll let them respond.
Just stepped away for 2 minutes.
So I'm not sure if it was the veterinarian loan repayment that got re-added in. I do know that the program that Bobby operates, which was for the healthcare loan, was added back in on the Senate side. But I'd ask Brenda to verify whether the veterinarian loan program was also added.
Okay, we'll ask her when she gets back in.
I have that answer.
Oh. Thank you, Bobby.
Yes, the veterinarian program for the applications that we're presenting today, those are covered. They're on a different cycle, so those will be awarded within our current budget. Moving forward, yes, it is sounding positive, and that would be the awards for 2022, and it was included with our healthcare professional loan repayment. So it is that program as well as the veterinarian and the dentist. And that has been on the in Senate Bill 2004. It has been considered in our optional budget request, and it does look positive. So Brenda, I don't know if you have any more to add to that since you're here.
Yeah, I'm sorry. I had to step away real quick. I didn't hear the question.
The question was with regard to the continuation of the veterinary loan repayment program in the next biennium, that it had been removed from the budget and looks like it might get added back in, and whether or not it was likely to continue.
Sure. The program itself was not eliminated, just we did a pause on the new slots for next biennium. So we are continuing to fund any commitments, including the ones you would approve today. And then, yes, as Bobby said, the Senate did include funding for new slots into 21-23. We are in good position going into the House, and I can cover that a little bit more in my update that under Dirk's agenda item, legislative updates.
Okay, thank you. So Beth, you would suggest that we make a motion to fund your ranks of 1, 2, and 3, which would be Mount, Christ, and Dahl today?
Yes. Yeah. And I know we sometimes have in the past when a letter is sent to the unsuccessful applicants, depending on how the committee felt, we either are silent on the issue of reapplying or we strongly encourage them to reapply. And everyone who reviewed the applications felt strongly that Dr. Hansen should apply again, and that he's a good candidate. It's just that how they fell out, and given the length that the others had been in the communities, they had a stronger community support and community tie.
I would agree, having read through them as well, but I'll let the rest of the committee chime in. Any questions for Beth regarding the veterinary loan repayment program scoring? Do you have differences in scores? Do you have anything that you'd like to discuss?
No, actually, in reviewing the applications, I didn't see this summary score until I had my selections made and they matched with what our group decided as well, or are recommending.
Any other comments? Do we have a motion to move forward with the top 3 scores?
Also move, Jim Brusso here.
We have a movement by Jim.
I'll second. This is Jenny.
Second by Jenny. Any further discussion? May we have a roll call vote, please, Miranda?
Birch,
Yes.
Brusso,
Yes.
Deansman,
Yes.
Poole,
Yes.
Roars. Roars.
I just couldn't get unmuted. Sorry.
Roars, was that a yes?
Correct.
All right.
Final
Motion
vote
carries.
is,
Sorry, Miranda.
it's okay.
5-0, motion carries. All right. And then now with regard to the Hansen application, is it the consensus of this council that we encourage Dr. Hansen to reapply in the next cycle?
I agree.
Yes.
Yeah,
There you go.
agree.
So we would support you in encouraging him.
Thank you very much. I appreciate it. We continue to be really grateful that this program exists. It's been really helpful to a lot of veterinarians.
Okay. Any other updates from the Department of Agriculture and the veterinary program, or anything else this council needs to know about?
I don't think so. I think we had the Health Council office did receive a letter from a previous recipient that they were going to be leaving their service area and transitioning to a small animal practice. I think she had perhaps 1 year remaining. Bobby can probably speak to that more specifically, but that hasn't happened very often in the, since we changed the priority ranking to put everybody on an even playing field, residents and non-residents. But I think she's only about a year early. She had sent a very professional letter just explaining that why she was leaving, and just to change her focus to work with a mentor that she really enjoyed. So again, that doesn't happen real often, but she did stay for, I believe it was 3 years of the contract. So.
Okay, thank you. Yeah, Bobby did present that letter, and it was nice of her to write that. We thank her for her professionalism.
Yeah.
So, any other questions for Beth? Okay, hearing none, we'll move on with the agenda.
Thank you much.
Thank you. Dirk, legislative updates.
Thank you. Yeah, I'm going to do something dangerous and try to use technology, so bear with me. Apparently I'm not doing it right. Can you see that?
I can
Yes.
see it. This is Jim.
Yes.
Thank goodness. We'll call that a giant win for me.
Good.
Thank you, Chairman Poole. As the topic indicates, it's our 2020 legislative update for the State Health Council. Session has been a really active session for the Department of Health. Kind of feels like a bit of a pinball lately. So I'm happy to dive in. Just in general, bills by the numbers for the Department of Health that we have tracked in total 137 bills. As of yesterday morning, I know the House went very, very late last night. But as of yesterday, we had 83 bills still active and 54 of those bills had been defeated that we were tracking. And so I guess my perspective in this update is it's going to be a really high level because of the number of bills. I'm not intending to go through 83 active bills or anything along those lines. But if there is questions or comments on specific bills that you guys want an update on, I'd be happy to help with that. So the first bill we did want to talk about specifically is Senate Bill 2004, and that's the Department of Health budget bill update. And I'll actually kick it over to Brenda to give the details and specifics on this. So Brenda.
Good morning. Thank you. Regarding our Senate Bill 2004, the last time we had met and discussed budget was actually our proposal that went before the governor's office and OMB. So now the update I'm going to give you will be on what the recommendation will be, and I'll kind of explain to you how the update relates to the executive budget. And I promise this won't take the rest of your time. I'll keep it really brief. Starting with our budget strategy, I walked through a few of the reductions we made to meet the 85% general fund budget target. And I'm going to start with that because that's where the executive recommendation added funds back in. And then I'll move into COVID as the last item. So our tobacco program, as a refresher, we reduced general funds by $1.1 million. And the executive recommendation added back that funding from the Community Health Trust Fund and it added an additional $88,000 on top of that. We're very happy to have received that funding and have that kind of support from OMB and the executive office. And that addition was also supported from the Senate. So we're in real good position going into the House when it comes to our tobacco budget. On top of that, related to the tobacco budget. Yes.
Regarding the tobacco program, is the funding source for that then the tobacco settlement funding that had been moved from other sources?
Yes, Dwayne, we do still collect funding from the tobacco companies. That funding then goes, all of it now, 100% of that goes into the Community Health Trust Fund. It used to be split between Education, Water, and the Community Health Trust Fund. Last legislative session, all of the payments made by the tobacco companies now go directly into the Community Health Trust Fund. And then they've also added the Department of Human Services as another entity in which is spending from that fund. So between us and the Department of Human Services. But now tobacco will be funded from the the Community Health Trust Fund, which is the tobacco proceeds.
Okay.
And then there's also a small amount of federal funds that support that program from the CDC. So did that answer your question, Dwayne?
Yes, it did. Thank you. And it's nice to see that money that's coming to the state because of causes is actually going back to the causes.
Yeah, I agree. We all agree. We think that is a great decision by lawmakers. The other thing too is the Senate also restored additional funding for tobacco funding given to the local public health units. In our budget proposal, we had made a reduction in that area in the amount of $647,000, and that was based on unused funding that had in the past been allocated out to the local public health. They did not spend. So when we were looking at reductions, that's where we looked. And then when the money was restored, we also have database evidence that shows that an impact on cessation with tobacco is best served through media and contacts. The increased number of media contacts or connections that are out there results in an increase in the number of calls to the North Dakota Quit line. So having walked through that with the Senate, they chose to add another $397,000 for local public health. So restoring a great portion of that reduction. Their funding will then be $6.25 million for tobacco efforts. We talked a little bit about loan repayment when Dr. Carlson was with us just moments ago. We did have also in our budget a reduction in this area so that we were going to pause because of revenues in the state. We would not be allocating out loan repayment next biennium, not discontinuing the program, but rather taking a pause. We did submit an optional request to restore the slots that we normally have given, the 3 in each discipline, 6 in behavioral health, and 2 clinical psychologists. And the Senate did put that funding back into our budget. So they funded our optional request. So we are in good position to move into the House on that as well. That does include 3 veterinarian positions, and those slots are each year of the biennium, so consistent with what you've seen this biennium. The next area where we had made a reduction to meet our target was the fetal alcohol program. That program was reduced as we thought it better aligned in the Behavioral Health Division of the Department of Human Services. The Senate, that was supported by the governor's recommendation, but the Senate did add funding fully back in for that program, just over $350,000. And then there were some small amounts that were supported by the executive recommendation in the Senate, reducing our temporary salaries and doing some revenue offsets. As you recall, maybe we are going to receive more indirect federal grant funding for administrative costs, and then Life Safety and Construction can run the program entirely on the fees they collect. And so that was supported by the governor's recommendation, and the Senate also supported that funding shift. There was another budget line item that was added in the executive recommendation, and it included $3 million for public health strategies. And these were the strategies that were developed and led by the work of Dr. Joshua Wynn of the University of North Dakota. $3 million was set aside as a special line item to address public health strategies and to further efforts that we were already working on in the Department of Health. The Senate did not support this funding, and so that amount was removed from the budget as it moves over to the House. And then lastly, as it relates to some of the strategies before I get into COVID, was the IT unification. That's an effort that started last session with some agencies whose technology team members were unified under the North Dakota Department of Information Technology. This year, we're included in that unification process. The executive recommendation had included 5 positions. And after working with North Dakota Information Technology, we realized that one of the positions is no longer technology, but rather is related to program. So the Senate did make that change. And instead of 5 being included in unification, there will be 4 FT from the Department of Health slotted for unification efforts and transferring the FTE over to North Dakota Information Technology. However, they would still be embedded in our agency. And then finally, I want to talk about the optional requests that were supported and at what level. So starting with the Forensic Examiner's Office, you were able to meet Dr. Barry Miller today, and we had requested 2 technology solutions that would improve efficiencies. The first being an update to our electronic medical records in that office that was approved. And then also we had requested a full body imaging system to be used rather than taking separate x-rays of the body once it's received at the office of the forensic examiner. Both of those were supported by the governor's recommendation, and both were supported by the Senate. Also related to forensic examiners, we talked about how, earlier you talked about how autopsies are performed in the state, and UND does do the autopsies for the 21 eastern counties. That contract we have with them has not seen any increases per se for many biennia. We did increase the funding this biennium in negotiations with UND to continue the effort, but then we also submitted an optional request to provide them a generous increase for their work and for the level of help they are providing us. The executive recommendation supported a 10% increase in that area, and that was also supported by the Senate. And then lastly, regarding COVID, we had developed a budget for working through the work efforts related to COVID back in August. And things have been ever evolving, as you all know, and through your meeting in the fall and then a subsequent meeting in December, case numbers went up, they've come back down. So that budget and optional request we submitted had some numbers that were rather high for what we were seeing at the time the governor recommended his budget for COVID-19. So we had requested $263 million. Now, again, remember that was in August when cases were building and high. And the governor did approve a COVID budget of $95.2 million. And $54.5 million of that was general fund. After we went before the legislature and the session started, Kirby mentioned to you 2 sizable grants that were approved. These grants were approved December 27th in a president's order or bill in the federal level. So that funding has helped us offset the general fund request in the area of COVID-19. $45.3 million were reduced from that general fund request. And so that was looked on very favorably, as you would imagine, by the Senate and adopted by them. And so our general fund effort related to COVID is now down to $9.2 million rather than the $54.5 million. Still in total, it's an effort of $95 million. And it covers the same areas in which I presented to you, I believe it was in November when I presented our proposed budget. The other thing this optional request had in it was the request for additional FTE. Again, building the budget back in August, we had requested 43.5 FTE for the effort. The governor and OMB supported 22.5 FTE for the Department of Health to continue their work, knowing that public health goes far beyond when COVID ends, and that the effort, we just really clearly, it was understood and apparent that we just weren't staffed properly in order to deal with things such as a pandemic or other issues that come our way. So of that 22.5 FTE, 12.5 of those were supported by the Senate. And so we're happy to have an increase in our workforce. We were happy they supported a good part of the request for FTE. And so as we move over to the House, we will have a COVID budget at the recommended level of $95.2 million. And then also we will have an additional 12.5 FTE that we will be able to talk about in front of the House, and then also talk about the 10 that were not funded. And so I'm open to any questions, but that's an update on Senate Bill 2004. Thank you, Dirk.
And just one other additional update is there was a study that was put into the budget bill that does directly impact the Health Council. And so there was a study put in to examine kind of roles and authority in terms of state health officer, health council, and the governor, kind of the issue that we ran into a couple times during the pandemic. And so there was a study that was recommended by Senator Mather and adopted as part of the budget as well.
Thank you, Dirk, for mentioning that. Sometimes I get wrapped up in the numbers. There was another amendment that was added, and this is number related. They did also propose that the Health Council members be paid the daily amount provided to legislators per day. So it is changing the compensation from $62.50. And I apologize, I'm not sure where they're at with the level of pay per day for legislators, but that was also an amendment that was proposed by Mathern and adopted by the committee and then by the full Senate.
So, Dirk, if I might ask a question, when it comes to that study and the functions of the health officer, but more importantly, the question that I have is related to the function of the health council. Are health council members going to be engaged and participate in this study?
So I would say that it would be a legislative study. And so they would be driving who's engaged and who's a part of the study action. I would say that there's a very high chance that the health council would be engaged as part of the study if it gets through both houses. And I apologize, Dwayne, I can't see hands with this screen up, so there's questions, just shoot them at me.
Hi, Jim here. I've got a question. There you went through some of the budgetary items. One was a $3 million request by Dr. Nguyen. Now, was that for, that was requested to help implement some of the recommendations that he made as the chief health strategist for the state?
Yeah.
Yes.
Okay.
Go ahead, Brenda.
Yeah, I was going to, yes, those were to address the goals and objectives that were outlined in his public health strategy document. Yes.
And has anybody seen that document? We had a brief presentation from Dr. Nguyen in October, but I haven't seen anything else from the state health strategist as to what they're recommending and whether or not that plan has to pass some muster with the health council or exactly who approves it, or it's just something goes on between the governor and the state health strategist. Can you enlighten me on that?
And I would dovetail into that. How does that then fold into the roles and responsibilities of the state health department?
Yeah.
And so that I would say in terms of the communication point, I do believe they finalized a document that might have been sent to the committee prior to voting. I know that it was just recently that they finalized that document. So
who finalized it?
I don't believe it's been sent out beyond like legislators and things along those lines. It is the communication and the drafting is being done by that strategy group. So the individuals in charge are Dr. Nguyen and Tammy Miller. I could reach out to see if we could get that copy of that and send it to the Health Council. But at this point, it was, like we said, defeated. And so we need to figure out if it's going to be emphasized on the other side to see if it can be brought back.
I can see why it'd be defeated because nobody has really seen it. No, at least we haven't seen it. I'd really like to see what kind of a document they came up with, because to me, it sounds like they're working a little bit at odds with what the State Health Council is supposed to be doing.
I would also point out, Jim, that one of the things that we scored really, really well on in our national assessment was the active participatory role that the State Health Council had played in helping set the strategic direction for the department. But that assessment was like 3 years or 4 years ago or so. But it seems like that's getting segregated. So I'm not sure what our role is. Maybe this study is a good idea.
Yeah, and I would say that the idea behind the health strategies was to be broader than the health department. So it would expand beyond not just the health department, but the health of North Dakota as a whole. And so that would be part of the, the funding obviously was housed in the health department. So we have a major role, but the idea was that it would be, I think everybody knows that public health is about collaboration and working with partners and stakeholders. And so that was supposed to be the vision of the health strategy group as a whole. They weren't just looking at what does the health department do? It was what does health in North Dakota look like? So what does it look like, for hospital systems? What does it look like for DHS? What does it look like for Department of Health? And so it was supposed to be a larger view or lens than just the Department of Health. And so, like I said, reach out to see if we can't make sure that you get a copy of that document. And it was just recently completed, and we'll see if they put it out to any other stakeholders as well.
I think that's good because, I think their prospect of getting this funding restored could really be enhanced if they had the support of the State Health Council. And since we are still in the dark about it, we can't really support anything that they're doing.
I would agree.
Okay.
So any other questions about the budget?
No, let's continue.
All right, thank you. So I'm going to kind of address bills in buckets. And so there was a lot of bills involving vaccinations and immunization. Specifically, I think it's in relation to the COVID vaccine and what can be mandated, what can't be mandated, what levels of influence should be had. And it was an intense couple of weeks where up to 11 bills were in session involving vaccinations at different levels. A majority of them were on the House side. I believe there was one on the Senate side. In total, 11 bills were involved with vaccinations. We feel fortunate that all did fail on the House or Senate floor. A lot of them would limit vaccinations. And so we were encouraged that the response was do not pass. So I don't know if there's any questions on the failed immunization bills. Okay. Another big topic that's popped up this session is marijuana. And I just copied kind of so you have a gauge of what's going on in terms of the marijuana actions. There was in terms of
week of February 7th was 10,700 and last week 13,500.
I don't know.
I'm not sure whose phone is off mute, but somebody said 13,000 some odd. So please mute your phone.
Yeah. Okay. Thank you. In terms of the medical marijuana program, there was a couple bills that were pretty impactful. Edibles did pass on the House side by 1 vote. So this would allow edibles to be included in the medical marijuana program. A lot of the other bills did not pass. So that would be the administration of pediatric medicinal marijuana that failed on the Senate side. We did have big concerns about brain development and in terms of pediatric patients and what that would entail when you get above 6% THC levels. Growing of medical marijuana also failed on the Senate side, and we oppose both those bills. The Medical Marijuana Advisory Board and designated caregivers, both of those bills, they passed. And so the idea is to reduce the fee that's assigned to designated caregivers and also increase the number of designated caregivers. So for example, a situation that you might see is if there was a child that qualified for medical marijuana, but maybe came from a divorced family, then obviously only one caregiver was assigned to that child currently. And so they wanted to make sure that got adjusted to allow for more than one parent to be able to serve as a caregiver role. They'd still fall underneath the patient limits. So out-of-state medical marijuana card holders, that also failed. That would have caused a lot of issues for our program. We wouldn't have known some states don't have the same allowable products as North Dakota, and some states have different limits in North Dakota. And so without having any sort of reference or check system, that could have caused a lot of issues within the medical marijuana program, but that also failed. Kind of the big news, I would say, that did pass is outside of medical marijuana, but it is the bill that addresses adult use of marijuana, and this is House Bill 1420. So what did occur on the House side is a bill was brought forward to legalize adult use marijuana for individuals over 21 years of age. The bill was allowed to be amended by a subcommittee of the Human Services Committee, and then they also included the AG's office and the Department of Health, specifically our Division of Medical Marijuana, to shape what it would look like if it was a regulated, well-regulated kind of adult use marijuana program. So it greatly mirrors what the medical marijuana program looks like currently, just kind of on an adult use basis. And so that did pass the House and is moving on to the Senate. There's a tax bill that's also associated with this, House Bill 1501, which has a 10% excise tax on the on the manufacturing facilities and a 15% tax on adult use products at the dispensaries. And really the push behind these bills is just, as you look at our neighboring states, there is a lot of approvals I mean, you look at South Dakota, it was approved by initiative measuring in the Constitution of South Dakota. And so the impetus was from the legislature was to kind of get ahead of it and be proactive in terms of shaping what an adult use program would look like in North Dakota, rather than waiting for an initiative measure to kind of shape what it would look like instead. And this doesn't include home grow. It doesn't include use in public areas. It can only be used in the home. So there is some things that were done to make it, from our standpoint, for the Department of Health, as regulated and safe for the public as possible. I would say that we still don't support the use of marijuana, but we were glad that we were able to be part of the discussion to help shape what the environment would look like. I'm not sure if there's questions on that. Hearing no questions, I will move on. There has been a group of 3 bills that kind of address emergency or state health officer authorities. I guess I'll just chime in my 2 cents on the bills. Senate Bill 2124, which did pass the Senate. The biggest concern I would have from a state health officer, and I'm only going to talk from a state health officer perspective, is there's language that says during an emergency or disaster declared by a governor or otherwise specifically authorized in this title. And so when they put that language into the standing order language for the state health officer, the problem is that we do standing orders outside of periods of emergency and disaster. Most notably, we do standing orders for pharmacies to do immunizations. And so that language is just a bit concerning because it seems to indicate that you could not do standing orders except for in periods of emergency or disaster. So that would be something that we might be looking at changing if on the other side, if possible. And then just the time limit for emergencies, 30 or 60 days. I think we know that this pandemic has gone a lot longer than 30 or 60 days. So that time limit, while not any sort of deal breaker, does reduce the maybe efficiency of dealing with it when you're in a pandemic. House Bill 1118. This is a bill that passed through the House. Similar, it would reduce emergency authority and state health officer authority. This one does not have the language about being within an emergency or disaster period. It does limit the geographical area. From my perspective, from a state health officer perspective, I don't think that's that big of a deal. I think most people will tell you that disasters happen on a local level. And so in general, a lot of the state orders could be shaped on a geographical level, and this would still allow for those pharmacies to get the immunization standing orders that they need, because we do them for each individual pharmacy. This would limit kind of the statewide mask mandates or anything along those lines, except for there does seem to be a provision that allows for statewide order when a governor has declared an emergency. So the three current bills in effect, this would be my preferred bill, just because I think it gets to what the goal is, and it's sort of to make sure that there isn't any kind of rogue activity that happens or any activity that extends beyond authorities or powers. But it doesn't, long-term affect how a state health officer would utilize standing orders. So to me, this is kind of the preferred bill from my perspective at this time. House Bill 1495, similar concerns. It's the time limit 30 days. That's something that you can obviously work around. There was some language that says the state health officer has to approve local orders. Going back to what I said, I just think that public health is best when it's served on a local level. They're the ones that know their citizens. They're the ones that know their atmosphere. And so just having a state health officer having to approve local orders, it was an interesting addition, I would say. And then it had the similar language of during an emergency or disaster declared by the governor, where once again, the biggest concern I would have is that we do standing orders outside of emergency or disaster periods. And so just want to make sure that that's not limited. Any questions about these three bills?
This is Dwayne. I really like the idea that our forefathers had when they were thinking about what a state health department does and what a state health officer is able to do, and that it basically depoliticized health decisions. And I see this as the pendulum swinging back the other way, and it worries me a little bit, but they're our legislature, they make those decisions.
I'm not sure that's a question, but I'll nod my head. Okay. Anything else? Then I'll jump over to House Bill 1247. This is a bill that would merge DOH and DHS into one agency. This bill did pass the House without much conversation last evening. There is some impact to the State Health Council in the bill. It would prevent the State Health, or I wouldn't say prevent, it would remove the rulemaking process from the State Health Council. I believe the other kind of actions and authorities that the State Health Council operates on would still be in place.
Dirk, would you mind sharing where did this bill come from, or what? Do you know any of the background on this bill? Why this was even brought forward?
I only know what I've heard in committee hearings is that it was they said that it wasn't in. It came from I believe Representative Wise is kind of the driving force behind it, and it was just from the perspective that they thought they could find efficiencies within the operations. There wasn't really any, I mean, I haven't been part of any planning or heads up or anything in terms of the bill. We haven't had any coordination with DHS of how it would work. And so it was really just a bill that appeared in front of, at least from my perspective, appeared in front of us at the start of the session. And I think it's a topic that has popped up over past legislative sessions. No bill that I'm aware of has ever been created to get to this level. But this one just, yeah, I think it's a legislative driven bill. I don't believe that there's any.
Hey, Jenny, this is Kristen. Here are the sales points that I've heard from the proponents of it. Number one is we do have some topics that kind of merge across DOH and DHS, especially in the behavioral health world. So think about the suicide prevention coordinator has been moved back and forth between the departments, and that ability to kind of break down some of those silos. That was one of the sales points with this, the administrative piece, but then also, with the struggles in finding a state health officer, one of the thoughts was, what if the state health officer didn't also need to be the administrator of the Department of Health? You could find somebody who wanted to focus on the public health piece and not have to be a good administrator as well. I don't know if those are all valid points or not, but those are the points that I've heard thrown out there.
Yeah, and those would be the same points that I've heard as well. And so
I have a question then to that effect. I haven't been privy to those conversations. Are the administrative responsibilities the limiting factor in the previous state health officers vacating the position, or the inability to identify a candidate that's willing to serve?
I would say no. I mean, we know that Dr. Mariani, it's pretty public of the reason he left. It was just in regards to the quarantine orders. Mm-hmm. And then in terms of hiring a state health officer, honestly, if we're being fully transparent, I do know that they have a candidate that they've talked with, that they've kind of identified, and that they were moving forward with. And in fact, it was this bill that gave them pause and hesitate to fully jump in. And so I guess that's what I'll say on that.
I would suggest that one of your predecessors got around that by hiring somebody really, really good for the administrative side of things, Arvey. And so I don't see that as a potential limiting factor. I think that's a little bit of a red herring in that sense. I'd also bring forward that the Department of Health also included the Department of Environmental Quality, and they were split off for efficiencies reasons. And also the regulatory versus non-regulatory component of it. But I have trouble seeing the efficiency in DHS and getting molded into that giant structure. But that's an opinion. Sorry.
So I don't know if there's any additional questions in regards to this, but yeah, this is obviously a bill that we're very tightly watching. And then the timeline in terms of merging, as I understand, would be July. And so it would be a quick merge.
Did it, the final vote on the bill, Dirk, what kind of support did it get in the House? Was it a,
I would say, yeah, it was. I would say it was a convincing vote in the House would be the answer. Wow. It was like, I don't know. I think it was like 73 to 27 or something along those lines.
Yeah, Dirk, it was 73 to 21.
Wow.
So I also take from your comments, Dirk, that you were not consulted as far as your thoughts on the merger of your department with DHS.
No, I was not.
Jim Russo here. I was just going to mention that I called Howard Anderson about this bill. He's a former member of the council and has really been one who's, I think, has been kind of shepherding this bill along, as from what I understand. He seemed to be pretty much in favor of it, for what that's worth.
Yeah, I believe that Senator Anderson is one of the sponsors on the bill.
Well, if this goes through, there might not be the need for the study or a health council.
Right.
All right. You going to continue?
And that is the last bill that I have that I wanted to just talk about. And so there's my thank you. And so if there's other specific bills that you guys were aware of that you wanted to talk about, I was sort of willing to dive into those now.
So I have a question about the bill to limit local authority to implement mask mandates, and whether or not the department has an opinion, and or the governor's office has an opinion on taking away that authority from the local level, when often we talk the authority should rest with local level on different issues.
Yeah, I would say that from our perspective, we'd be opposed to that bill. We do really believe that local decision makers know their community, know their population best, and we would heavily support kind of local public health action, because we do believe that's probably where the strongest and most effective public health activities comes from. So that's
that testimony.
I do believe Kirby gave testimony on that, but maybe I'm mistaken. and it did get a do not pass out of committee. It was just on the floor that changed.
I have a question for you. I've watched a couple of the hearings, and I see a significant proliferation of non-scientific beliefs amongst our legislators with regard to how they approach some of these things, basically with things like there's no scientific evidence that masks work. Those types of broad generalized statements. How does the department communicate with legislators to help make sure that they're using the best available science in their deliberations as opposed to internet belief systems?
I would say that we have reached out to various legislators throughout the process and provided scientific studies at different junctures and had conversations before session, after session, mid-session about the different topics. I would say that it's not always persuasive to them. And so it sometimes you can provide the information. That doesn't mean that they'll believe or follow the information.
Well, I appreciate that you guys are reaching out with your professional opinions. So thank you. Any more questions for Dirk? All right. The General State Health Officer update then.
Well, I think we hit it pretty good. The two areas of focus right now is still COVID, even though the numbers are reducing. And I guess maybe this is my time to tout the team a little bit about how great they've done during the COVID response. We've been top 5 in terms of testing from all states. We've been top 5 in immunizations for all states. We have one of the lowest positivities of all states. And I believe it was Wallet Hub recently classified us as one of the safest states to be in during COVID. And so obviously this happens with a lot of support and stakeholder involvement and agencies, but the Department of Health has been the lead. And so for us to do that well across all different metrics, the light doesn't get shined bright enough on that. So maybe I'll just take this moment to say thank you to the team members that got us to that point that allows us to feel like we're in a more comfortable place because it's really all the effort and work that they put in that gets us there. And so sometimes the numbers aren't shown to see how significantly and what a good job this team's done. So I'll just say it. So there's that. And then I would say that.
Dirk, can I interrupt just real quick?
Apparently.
Can you yes, I'm sorry. Have you mentioned about Molly?
I was going to get that right next.
Thank you.
Good cutoff. No. And so it leads into, well, and it's not just Molly, because Molly's done a great job. So great a job that the North Dakota Public Health Association did just announced this morning that she is going to be awarded the Public Health Worker of the Year award. And nobody deserves it more than her for her work that she did, not just in vaccinations. Even when the pandemic started, she was really involved in setting up contact tracing and the initial surge of activity. And so, but Kirby, you won an award too. I want to see if I can. Yeah, if you look at this magazine, you can see his bright, shiny faces. He is the North Dakota NDMA's Friend of Medicine Award winner this year, too. So our team has done an amazing job. And I think I'll just take this time to say thank you to them because not only have they been award winning, but they've really, by any metric, they've been really successful at their work. So I would say thank you to that team. And so that'll be my update.
Yeah, and I think I would echo that, and I appreciate Molly and Kirby and others, and one of the most impressive things to me is their humility as well, in that they're recognized, but they give credit to all of those people that raise them up on their shoulders as well. So I really appreciate that. Okay, then under other business, we had a subcommittee developed to address some long-term care issues that have been raised with regard to reporting. And I believe Bridget and Jim will be giving us an update.
This is Jim. I'll just say that I've had several contacts with Bridget and myself. We've made some suggestions, and I think those have been taken very seriously. And I think maybe I just would ask Bridget to take over from here and tell us what has resulted.
Thanks, Dr. Russo. I'm going to share my screen best I can here. I can get it to work.
So it's just a general question while you're working your way through that. How do you, when these come in, address whether or not it's a social worker type complaint or whether it's a health complaint, and how does it get differently routed? That's just an informational thing from my perspective, not being well enough read in your processes.
So, Mr. Poole, what do you mean by a social worker type of complaint versus a health complaint? I'm not clear on what that means.
It's about a patient's health and physical well-being and treatment in the health perspective versus not getting along with staff or that sort of thing.
Okay. So we have a triage process, and the only complaints that we have jurisdiction over are those that there's a regulatory component to, which would be the quality of care. So if it's a disagreement, like a labor dispute, not getting along with the facility, we do not have regulatory jurisdiction over that. So we would say we don't have jurisdiction over and refer them elsewhere. Say, for instance, if a family is having an issue with a nurse, we refer that family then to the Board of Nursing, because we just don't have jurisdiction over those type of complaints. So the only ones that we would focus on would be the ones that the health department through licensing or federal certification have jurisdiction over.
Okay.
I think you guys, can you see my screen? I'm not sure what you're seeing.
Yes.
Okay. All right. So we took the suggestions from those that we heard from and did make improvements to our Department of Health website. And I just want to walk you through what we've done. So I'm just going to the Health Department's home page right now. There is a button way down here about contact us that they can file a complaint here. And we do get them that way, but we wanted to, based on your suggestions, to be more transparent. So how you get to us is the regulation and licensure tab. So if you click on that tab, there's all the different programs that involve regulation.
My screen still seems to be on your very first screen you brought up.
Okay. Let me share this one. So are you seeing the regulation, licensure, and certification screen now?
That one's now a live screen. Do you want to back up to getting there now?
I'm wondering if I'm going to have to do this each time. Clint, do you know, is there a way to go live when I'm doing each one of these? It seems like every time I click a button, I have to reshare the screen. Is there a way for my demonstration to follow me as I click the links of the health department's page? Or are you able to do that and I can walk you through it? Clint, what's the best way? Yes. Okay, I'll share my entire screen. Thanks, Clint. Okay. So are we seeing the regulation, licensure, and certification tab now?
Yes.
Okay. So how I got to it, I went to the North Dakota Department of Health's homepage. And I went to regulation and licensure, which takes you to regulation, licensure, and certification screen. And I hope that this is following. So I'm just going to go through a couple of these. So let's say somebody wants to file a complaint on an ambulatory surgery center. If you click on the plus sign, there's going to be a link on how to report a concern. So we've now done that for each type of facility that we regulate. I'm going to go over to long-term care because that's kind of what prompted this subcommittee. If we go to the long-term care tab and go to the how to report a concern link, it brings up a whole new area that talks about how to report a concern. And we added 2 bullets based on feedback from Dr. Brusso. And this is something that we do tell the complainants when they contact us, but it was a very good point to include it here. We always want the complainants to go back to the facility's administrator or director of nursing. And then we also added information about, have you talked to the primary provider or the facility's medical director? Because we do realize that in most cases, the facilities are best able to respond to those concerns. However, there's times when that just isn't working or feasible, or that might be part of the concern. So we did include then, if you wish to file a concern, please contact us at, and then we have our address, our phone number, our fax. We have a link to a more general HF concerns at nd.gov. So we changed it from LTC concerns at nd.gov so that it would encompass all health facility concerns. So that goes to an email box that's monitored by one of our administrative assistants, plus myself and the program managers. And we also, in the meantime, developed a complaint intake form that was kind of talked about on the last State Health Council, that there might be a preference for a form. So if a facility or a complainant feels more comfortable filing a facility complaint via form, we did develop this form. They can fill out all the boxes, and then they can email it, mail it. There's an option to print so that they have it for their own records. Also, we feel that this form is just a stopgap until we can develop a web-based form that I kind of mentioned at the very beginning. So the health department already has an option to contact us and file complaints or ask questions. And we put in a request through NDIT about 3 weeks ago to see if they could elaborate on this form. This will replace that PDF form, the fillable PDF. And right now, if you go to Health Topics, you can already do a concern here, long-term care concerns. We want to make this more general, just to be general complaints, and then there'll be drop boxes for type of facility, and then we collect more information, and they can submit it to the health department that way, and it would come directly to us via email as well. So we feel that we've made ourselves more transparent by including information on our health facilities homepage under each provider type, giving them our address, our phone, our fax, our email, developed a form, and then we're working with NDIT to make this web-based form also more accessible specifically for health facility concern. So that's what we have done in response to your concern. Does anybody have any questions for me?
Jim here, I'd just like to say that I really like what you've done there. To me, that looks very well organized, and the rules are easy to follow, and I think you did a great job.
Thank you, Dr. Brusso.
I think from the consumer perspective, it's clear how you let a concern be known now, whereas before it was, the complaints I was getting was nobody knew how to file a complaint. So I think that's very open to the public, and I appreciate that.
Okay. Thank you. Thank you for the suggestions. We're always happy to make ourselves more accessible to the citizens we serve. So thank you.
Sorry, I had myself muted. Any other old business to attend to? Any other business to attend to?
Jim here, one more thing I'd like to add. I'm really getting tired of these teleconferences. I hope that by the time of our next meeting, we could at least have the option of coming to Bismarck and everybody meeting around the table like we used to do. I hope we make an effort to do that for our next meeting.
Well, by the looks of most of us on this call, we might be qualifying for a vaccine pretty soon.
I've had mine, so.
Me too.
All right, I agree. I echo that. Are there any other comments from the commission or from staff before we close? All right, hearing none, I'll call this session of the State Health Council to a close. Thank you.
Thank you.
Thanks, Dwayne.
Thanks.